Hi, my name is Jim Blankenship. I'm an interventional cardiologist at Geisinger Medical Center in Danville, Pennsylvania, and member of SCAI. Recently, SCAI published a paper written by a writing group, of which I was part, on ad hoc angioplasty, specifically aimed at addressing situations in which ad hoc coronary intervention is appropriate and situations where it may not be appropriate. There are three different reasons why we undertook to write this paper at this time, and I'll review those briefly. First of all, it's not the first time that we visited this topic. We have put out papers on this not only in 2000, but again in 2004. And since we've had 8 years elapsed since the last version of this, we thought it was time to update the paper in light of many recent developments, which we'll talk about in just a moment. Second reason to put out the paper at this time is that it represents another in a long line of papers and projects from SCAI aimed at improving the quality of interventional cardiology practice by members of SCAI. And specifically, we have most recently the appropriate use criteria from 2009, updated again in 2012, and the PCI guidelines from 2011 that were just published last year. There are other papers written by SCAI members specifically addressing such topics as radiation safety in the cath lab, infection control in the cath lab standards, and many other topics. And this represents one in several consensus papers that have come out recently addressing such topics as multivessel intervention and how to stage it, and now ad hoc PCI. A third reason to put it out at this time is that recently we've had several major publications that have made interventional cardiologists and others consider whether we're doing intervention inappropriately in some circumstances. Certainly there is reason to think that perhaps we should pause before plunging into a coronary intervention after doing a diagnostic catheterization. In particular, we have courage that suggests that in many cases medical therapy is a reasonable alternative. And so instead of plunging into an ad hoc PCI without thinking about it, we should at least consider whether medical therapy represents a reasonable alternative. At the other end of complexity of disease is syntax, which suggested that for some patients, bypass surgery may be better than multivessel coronary intervention. And so at the most complex end of the disease spectrum, we have the heart team approach, where a patient can be taken off the table after a diagnostic catheterization and then receive input from not only the interventional cardiologist, but also the cardiac surgeon and perhaps family members and primary care doctors, helping that person to come to a decision about what is the most appropriate treatment for them. So in this era of greater thoughtfulness before plunging into coronary intervention, we thought it was time again to update the ad hoc PCI recommendations. There are a couple of very important takeaway points from the paper. The first is regarding informed consent, and specifically, I believe that I and many interventionists tend to provide informed consent to the patient before diagnostic catheterization with respect to what is a common, everyday, fairly simple angioplasty. But in fact, if the diagnostic catheterization shows relatively more complex disease, and if we proceed with coronary intervention at that time, we really should have provided informed consent that applies to that more complex coronary disease, which of course has some higher risks and perhaps different sets of alternatives. And so before proceeding on after diagnostic catheterization with a relatively more complex multivessel intervention, we should have provided good informed consent that covers that kind of situation. So I think that calls for interventionists who are ready to perform complex interventions on the spot to make sure that the informed consent covers those kinds of situations. The second point is really aimed more at payers and insurers, and that is to emphasize that in many cases there are circumstances where it is quite appropriate to do a diagnostic catheterization one day and then come back on a subsequent day and do the coronary intervention, where there is pressure from some insurers to bundle the services and get them all done on one day, which of course is more efficient and also ends up costing insurers less because they're basically paying one fee to the hospital and only one fee to the physician, as opposed to when the procedures are done on different days, they're paying out two different payments to the physician, and at least when they're done as outpatients, to the hospital as well. And the message here is that there are many times when it is quite appropriate to split these into different procedures on different days, and that neither hospitals nor physicians should be penalized by insurers when that is the appropriate kind of care to provide. The paper on ad hoc PCI was published before the FAME2 results became known. The paper, as it currently stands, does emphasize the importance of doing physiologic invasive testing on lesions in cases where we don't have independent evidence of ischemia from stress testing. So in the case where we see a indeterminate lesion by angiography and are not sure whether to proceed with coronary intervention, the paper does advocate, as did the PCI guidelines, that we would do invasive testing, most commonly with FFR. I think this approach was further confirmed and validated by FAME2, which shows us that, in fact, it is a effective way of treating coronary arteries, but I think that it does not change the recommendations from this paper on ad hoc PCI.